Good afternoon, everyone. Welcome to session 5, entitled What Does the Future Hold? My name is Tokame Mahmoudi, and I'm going to be co-chairing this session together with Dr. Nyarato Mgodi. I'd like to encourage everyone to put their questions in the chat. There will be 2 presentations in this session, and questions and discussion will be held after both presenters have completed their talks. So please don't forget to put in your questions in the chat. There will be a live discussion afterwards. I'd like to take this opportunity now to introduce the first speaker, Dr. Casper Rox, who will be talking to us about HIV cure. Where are we? Dr. Rox is an internist, HIV infectious disease specialist here at the Erasmus University Medical Center in Rotterdam in the Netherlands. He leads the HIV clinical research unit. He did postdoctoral fellowships at Chelsea and Westminster Hospital in London in the United Kingdom with Dr. Anton Pozniak, and in molecular virology with Professor Charles Boucher and myself. We very much look forward to your talk.
Good afternoon. I'm delighted to present an update on HIV cure here at the INTEREST conference. This is Timothy Brown, also known as the Berlin patient, who unfortunately passed away last year. But he still stands for the hope that curing HIV is possible. And much research is going on to reach a cure, and I hope to give an impression of where the clinical HIV cure field stands here. And since this field is broad, I will try to highlight the main advancements in its field. And this will probably also elucidate where we are now and might also shed a light on what the future holds. It is a good idea to first answer the question whether we still need a cure. Because especially non-HIV specialist healthcare professionals can ask that, and I think many of you are familiar with that. They rightfully say, however, that antiretroviral therapy has dramatically increased life expectancies of people with HIV compared to those without, as is also evident from this study from the United States of America. Many other studies from different settings all show that once antiretroviral therapy is introduced, life expectancies indeed near normalize. But is that sufficient? Well, in my opinion, finding a cure remains essential. Because while life expectancies has increased, from the same study we can also appreciate that people with HIV live twice the time with comorbidities than someone without HIV, and this number is strikingly unaffected by the introduction of antiretroviral therapy. Second, with viral persistence and the need for lifelong therapy, mutations and emergence of important viral resistance with HIV variants of concern can arise. And this is something we've seen happening before with the increasing use of NNRTIs, for example, in the cities studied in this study, and the fear, I think, rightfully exists that this might also happen with the newer drug classes we have. A third important aspect is that the average cost of a first-line integrase inhibitor-based antiretroviral regimen is higher than the average annual income on Earth. And this signals the huge financial challenge for worldwide antiretroviral therapy coverage. And last, the importance of stigma can't be ignored, and not having to take a daily pill can certainly help with that. So huge excitement emerged when the Berlin patient was cured after undergoing myeloablative induction therapy followed by consolidation through a double allogeneic hematopoietic stem cell transplant from an HLA-matched CCR5 delta 32 deleted donor for his relapsing acute myeloid leukemia. And this has been successfully repeated in a few patients that became known under the city names where they had been treated, but not in others. Several key factors might be associated with viral rebound, and of course this is the donor choice, but also the time on antiretroviral therapy, and especially the moment of antiretroviral therapy interruption seems important for success. Interruption of therapy after successful engraftment looks optimal. But however, something like a mucositis can also result, and this happens quite often, of course, in stem cell transplant patients, in insufficient drug absorption and exposure. And this, together with a potential late engraftment, can in turn give space to viral tropism shift to escape the viral entry bottleneck of donated CD4 T cells That was the whole idea of the transplant. So despite the importance of demonstrating the proof of cure that it is possible, stem cell transplants are no safe or scalable option due to their substantial mortality and morbidity for the far majority of people with HIV. A significant effort is being done by the international research community to find a cure for HIV, and only in the clinical trial field alone, already almost 200 studies are registered to study different strategies to cure HIV. What I will do here is try to highlight the current status of the main strategies by focusing on several key clinical studies. So, gene-based therapies to eliminate CCR5 receptors can be promising based on the stem cell transplant results. And actually, several gene editing techniques exist. And with a gene editing technique called zinc finger nucleases, researchers were able to disrupt CCR5 and autologous CD4 T cells. And the stable number of gene-edited CD4 T cells was maintained in patients after reinfusion. Despite their persistence and decay in HIV DNA during treatment interruption, all patients rebounded upon analytical treatment interruption, however. And probably follow-up studies in this field should try to increase the yield of CCR5 disrupted cells or include conditioning schemes. Along the same line, in 2019, a report on another gene editing technique, CRISPR-Cas9, that showed that it could offer potential benefit in HIV patients. A case report underlined its potential, where since a patient here with HIV and an acute lymphoblastic leukemia received a CRISPR-Cas edited CCR5 ablated hematopoietic stem cell transplant after cyclophosphamide conditioning and total body irradiation. So here, full donor chimerism with a long-standing persistence of the edited donor lymphocyte was achieved at approximately 5% prevalence. But the viral rebound occurred swift, despite the upregulation of the proportion of disrupted cells. So what can we learn of this? I think that stem cell transplants and gene editing therapy hold promise, but need further refinement. So how about other strategies? Alternatives evolve around either interventions that decrease the size of the viral reservoir or to enhance HIV immunity. Using latency reversion agents, or LRA, to shock reservoir cells makes them express antigen and potentially amenable to immune effector functions. And it becomes increasingly clear that probably a combinatorial approach of both, known as shock and kill or kick and kill, is probably warranted. So how about using antiretroviral therapy alone? Well, this can induce a viral remission after antiretroviral therapy interruption in subset individuals for sure. And this is most likely to occur in patients who initiated their therapy during acute HIV infection, probably due to a smaller reservoir. And this has been shown in the Visconti cohort, as shown here on the left graph, and also in the CHAMP meta-analysis of 14 treatment interruption studies. However, as you can see, that this does not happen in all acute HIV patients that interrupt therapy, and the precise host factor associated with control remains unclear, because there are no exceptional anti-VIH immune responses to be appreciated or protective alleles in this population. And then I mean the population that gains control, of course. Also, with a small reservoir being an important factor, some patients who initiate antiretroviral therapy during chronic phases of the infection might also be able to achieve control. And the Loviret cohort, which is shown on the right, suggests that this might be true for a relevant proportion of patients. Because here, as you can see in the red box, an estimated 10% at a low reservoir and 1% at no HIV DNA detectable at all. As we probably all know, total HIV DNA is a sensitive but not a precise marker of the replication competent reservoir. So the question is still out, which patient would benefit most or benefit at all from treatment interruption? So this is a non-exhaustive and subjective list of the main LRA that have been used in kick and kill trials. And a common conclusion of these compounds in clinic is that they can, to some extent, successfully reactivate HIV from latency, as here with romidepsin. However, the amount of reactivation has not yet led to a clear reduction in HIV reservoirs overall or in replication-competent compartments. And in addition, some of these compounds, including romidepsin, can be toxic to immune cells, including anti-HIV lymphocytes required for reservoir eradication. Therefore, more potent kick-and-kill strategies are likely necessary. But combining agents can lead to success, but we don't know very well often how these combinations will behave. Pharmacokinetics can have unpredictable interactions with toxicity, and preventing toxicity remains and should remain an important focus of our research field. So latent HIV-infected cells is enriched by memory CD4 T cells that express immune checkpoint molecules. And these molecules can also be blocked by immune checkpoint inhibitors, targeting, for instance, PD-1 or CTLA-4. And this was an interesting sub-study of the AIDS Malignancy Consortium, where antiretroviral therapy suppressed patients with advanced malignancies were assigned to anti-PD-1 therapy with nivolumab, with or without anti-CTLA-4 by ipilimumab. And as you can see, on the latency reversal was observed in dual treatment arm with some signals of replication-competent reservoir decay in a subset of patients shown here in the graph on the right. An interesting but also very complex field is the stimulation of cellular cytotoxicity. And this can be achieved by creating chimeric antigen receptor T cells, or CAR T cells. And the interesting thing is that these CAR T cells harbor synthetic receptors with an HIV-specific extracellular domain, which is fused to intracellular signaling domains. Also, if I think of it, it's very interesting, but the first CAR T cell trials already started 30 years ago and showed actually that this could be done quite safely with an adequate persistence of edited cells and potentially lead to delaying viral rebound. Newer HIV-specific CAR T cells that additionally co-stimulatory intracellular signaling domains are currently being studied. Stimulating immunity can also be achieved by creating virus-specific T cells with BNAb secreting function. And HIV-specific T cells are expanded in the presence of HIV antigens and cytokines, and then transduced with BNAb constructs for enhanced antibody-dependent cellular cytotoxicity. Or you can also make CAR T cell constructs that also express BNAb single-chain variable fragments to redirect CAR T cells against different regions of the HIV envelope. And clinical trials are underway with these CAR T cells. And a promising approach might be to use bispecific CAR T cells to minimize the risk of viral escape. But also here, an important point remains toxicity, and especially the cytokine release syndrome that can be associated with CAR T cells. Here I show vaccination studies. In a single-arm phase B trial, a decrease in the viral reservoir did not lead to sustained viral remission when combining a synthetic P24-GAG peptide vaccine, GCSF, followed by late reversal by romidepsin. And these results probably partially fueled creating the phase 2 open-label randomized clinical trial called RIVER, here shown on the right, that included acute HIV-infected patients. Here, no differences were observed between a combination of T-cell-inducing vaccine with vorinostat and the control arm during follow-up at all the endpoints. And the striking thing was that this was despite enhanced anti-HIV CTL effector functions. So in RIVER, no analytical treatment interruption was done, but in others, it was, and both the BCN02 study, which used an adjusted prolonged prime boost scheme of this vaccine that was also used in RIVER together with romidepsin, and also in the ALEX-002 randomized clinical trial where a T-cell inducing vaccine was studied, they both did an analytical treatment interruption. And in these trials, the viral rebound was not prevented, but interestingly, the viral set point seemed lower in a relevant proportion, suggesting some form or level of inducible control. And the ALEX-003 study is currently ongoing to study the vaccine in combinatorial approaches. To summarize, Age of a cure, where do we stand and where do we go? I think it is clear that we have a decent inventory now of potential cure drugs that can set the stage. And the next steps for now are to come to our personalized kick and kill strategies based on host and viral characteristics. Combinatorial approaches are likely necessary, but ensuring safety is a priority. Last, collaborative studies using the existing consortia can help building well-powered studies to find relevant signals of cure in subgroups. I had the privilege to work with Charles Boucher, and he often told me, don't just count the frogs you see in the pool, but understand why they are there. And in case of the reservoir frogs, the simplest way is that they are there because it is nice, quiet, and without predators. So focusing our efforts on these factors will ultimately lead to a cure. Thank you very much for your attention.
Thank you very much, Casper. Please don't forget to put your questions in for Dr. Rox, as there will be a discussion after both presentations. It's a pleasure now for me to be introducing our next speaker in the session, Professor Elizabeth Ann Bukusi, who will be talking to us about the future of PrEP in Africa. Professor Bukusi is Fellow of the African Academy of Sciences. She earned her general medical degree and master's in obstetrics and gynecology from the University of Nairobi. She then earned a certificate in international health, MPH, and a PhD from the University of Washington's Department of Epidemiology, a postgraduate diploma in research ethics from the University of Cape Town, and a master's in bioethics from Center for Bioethics and Culture at the Sindh Institute of Urology and Transplantation in Karachi. She is a certified IRB professional. She's a senior principal clinical research scientist at the Kenya Medical Research Institute, a research professor at the University of Washington, departments of obstetrics, gynecology, and global health, an honorary lecturer at Aga Khan University in Nairobi and Maseno University, Department of Obstetrics and Gynecology, and volunteer clinical faculty, professor at the University of California, San Francisco, Departments of Obstetrics and Gynecology and Reproductive Sciences. We look forward to your talk.
Geno Makin, hope for tomorrow. Pre-exposure prophylaxis in Africa. What is the future? If you don't know where you're coming from, you cannot tell where you're going. Maya Angelou. I'd like to thank the organizers for the opportunity to share with you our thoughts about pre-exposure prophylaxis and the future. I will use my country, Kenya, as a prototype for what we can think about for pre-exposure prophylaxis in sub-Saharan Africa. We have to know where we've come from in order to know where we are going to. What's the landscape like in Kenya? In this schema, I'd like you to look at what the overall incidence was like in Kenya and what our targets were for reducing the incidence. In general, we have been able to achieve our targets of reduction in new infections among male, among adults in general, and in the overall population. Where we haven't done as well is among the females. And of course, as a result, this also reflects upon children. I'd like you to think about the geographic focus and the priority populations who we target pre-exposure prophylaxis for. Adolescent girls and young women, female sex workers, men who have sex with men, serodiscordant couples, and of course, we cannot forget the general population. In Kenya, we have targets for each of these populations, hoping to be able to ensure access to individuals who need pre-exposure prophylaxis. But let me take us back to the history of where we've come from so that we can think about where we are going to. After the early trials for Kenya, we formed a national technical working group in 2016. The demonstration projects that started within that year were able to provide information that eventually saw approval of the generic formulations for pre-exposure prophylaxis. By May 2017, we had launched a national framework and started rolling out pre-exposure prophylaxis. What are some of the lessons that have been learned? PrEP was highly accessible, but this was only after intensive awareness and demand creation. The uptake was high initially, as individuals were keen to try it out. We ran into roadblocks. Persistence was a challenge. Adherence was a challenge for some. Some individuals felt PrEP just wasn't for them. For some of them, taking a pill daily when they were not unwell was challenging. The highly mobile younger population that is at risk tends to relocate in search of education or work opportunities. And then there wasn't the social support that made it easy for individuals who wanted to take PrEP to continue on it. But let's think about the regional uptake of PrEP, not just for Kenya, but for the whole world. And in this slide from AVAC, you can see that though Sub-Saharan Africa was on to a very slow start, by the last quarter of 2020, most of the uptake of pre-exposure prophylaxis was from the Sub-Saharan African region. If I focus it back to Kenya, who's currently taking PrEP? This pie chart shows you who has the lion's share in terms of the numbers of individuals who are on PrEP. The general population, about 31%. Discordant couples, taking the lion's share, 39%. Female sex workers at 21%. And lower numbers among men who have sex with men and people who inject drugs. What does that mean for us as we think about the future and these key populations who do need to access PrEP? Demand creation is one of the important lessons we need to think about. I still get surprised at the number of individuals who have no idea that a pill a day could keep HIV away. We haven't provided enough information or saturated information to enable anyone who might be at risk to access it. But even as we create demand, we must ensure that there is access and there is service delivery within healthcare facilities that may be already overburdened with other infectious conditions and other challenges. Once the individual who initiates PrEP takes it, how do we support them to adhere? How do we ensure that they can receive the support to be persistent in their taking of their pre-exposure prophylaxis? Policy adaptation and implementation of programs that allow for PrEP to be expanded and available are really important. And in the current landscape, where a lot of the PrEP has been funded through either PEPFAR or Global Fund, and with the diminishing funds coming from those particular areas, there is need to think about how do we sustain the costs of the programs that are offering PrEP. I'd like us to think for a moment about demand creation. The population in this region is expected to be about 1.7 billion by 2030. While currently the internet access may be at just under a quarter, it is expected that 3/4 of this population will have access by 2030. So as we create demand, can we think about more social media, virtual, internet-based platforms that provide information and enable individuals to be aware of what their options are? But as we make this information available, the question is, how do we provide the PrEP? We must think about moving from a predominantly healthcare facility, hospital-based access points, because this is a promotive product for avoiding infection, not for individuals who are unwell who need to come and get treatment. How can we enable access to testing? How can we make it more friendly? Must it require a provider? What are the self-testing strategies that would work? Can we use our antenatal care settings, our mother and baby clinic settings, any places where individuals who are well can be accessed to enable them to have opportunities to test and to access PrEP? Of course, there are target populations who we know are really at risk. The sexually transmitted clinics would be a point at which individuals should clearly access PrEP. However, many of these have been dismantled over the many years and may no longer have active service provision. Can we go beyond healthcare facilities to think about community-based options? Retail pharmacies, dispensaries. What are the safe spaces in which young individuals needing to access PrEP can actually access it? Are peer models viable? Remembering that these products are, however, prescription drugs that do require, at some level, oversight or interaction with an individual who has the required training as a healthcare worker. I think there are lessons we can learn from the contraceptive world. Contraception, like PrEP, is for prevention, for an individual who is well, but who needs to manage a certain aspect of their reproductive health life. How can we learn lessons from the contraceptive world to think about service delivery? How can we engage with healthcare providers who are a major stakeholder in being able to roll out PrEP? We recognize from this world that the high cost of initial service setup is often offset downstream as services become tailor-made and as access is improved and as the numbers accessing the services increase. How regularly should individuals who are on pre-exposure prophylaxis come in? We know that PrEP is not for life. It is for those periods when one does know that they're at risk and need to be protected. As some of the bilateral donor-funded programs reduce their funding, how can we ensure that there's subsidized government funding and support to enable citizenry access these products? And how do we deal with the gender inequities, recognizing that often partners play a key role in either enabling or not enabling access and use of these products? Remember that it's not an overnight thing. It took 10 years for PrEP to be available in many countries in sub-Saharan Africa. And there was a need for political will and financial support to adopt and implement these strategies. This required advocacy. This required commitment. We also need, and it's still a work in progress, to ensure there's social support and community involvement. Stigma is still a reality that people are dealing with even now. As I draw towards the end of my discussion, I think there are lessons we need to learn from COVID-19 as well. We need to be prepared for an increase in the demand for these services, especially in this era where there's been an increase in demand for healthcare services because of an unprecedented pandemic. Let's borrow from telemedicine that has become a new normal in many COVID-19 situations. How can we utilize it and enable appropriate clinical oversight? With COVID has also come the challenges of supply of commodities, supply of drugs, with a world that literally came to a near standstill. How do we maintain the supply chain? What about documentation? Can we use the same electronic systems to ensure that while we have a robust system of keeping documentation, we reduce the burden of unnecessary documentation? We also must remember that, as we're reminded by the COVID-19 pandemic and vaccine access, unless we address racial and ethnic disparities in health, we cannot attain the goals that we want to by keeping people healthy and enabling access to services that they truly need. I would like to acknowledge my team members for their contribution. And as I thank you for listening to me, I'd like to ask, what's your role in it? How can you make the future of PrEP a reality for Africa? Thank you very much.
And we can continue from there.
Because we will be implementing this in this season of COVID-19, I think there's some important lessons that we can learn from the pandemic. We need to prepare for an unexpected increase in demand of healthcare services. PrEP should be made available, even as we anticipate that our healthcare services will have an increased demand because of that pandemic. But maybe there are things we can benefit from. In this COVID pandemic, telemedicine has become part of our new normal. Can we borrow from it? What are the things that we can learn and implement by making PrEP available using telemedicine? Demedicalizing the access of services with some kind of remote clinical oversight. There have been challenges with supplies during the COVID pandemic, and how can we ensure that the chain supply of demand is made accessible despite the challenges with transportation and with goods moving from one place to another and with manufacturing? How do we use this same situation to ensure we can maintain robust documentation that allows for appropriate decision-making while reducing the burden of unnecessary documentation? And one important factor that we have learned as we've thought about the COVID-19 vaccine access and distribution, unless we address issues of racial and ethnic disparities, we will not be able to keep people healthy and to provide the services that they need if we do not address these concerns within the global world that we live in. I would like to acknowledge my team for their support in the preparation and in thinking about what the future of PrEP looks like for us. And as I end, and thank you for listening to me, I would like to ask you a question. What's your role and what part can you play in making PrEP for Africa a reality? Thank you.
Thank you very much, Professor Bukusi, and I'd like to at this point hand the discussion over to Dr. Nyerato Mgodi. Thanks very much.